So I'd like to start this session, the managing coronary calcium, the insight and approaches. As you know, the coronary calcium is a big enemy for our interventional cardiologists. So I hope today's topic is very useful for all of us. So I'm Dr. Satoru Otsuji from Osaka, Japan. And I'd like to co-chair with the session with Myeong-Ki, one of my good friend, very good friend. And we have a very excellent panelists, Dr. Jung-Yong Hahn, Yuji Hamazaki, and Dr. Jung-Kyu Hahn, and Scott Harding, and Dr. Shozo Ishihara, Dr. Jang, and Dr. Holland, and Dr. Akiko Maehara, and Dr. Kambis Mashayekhi. So I'd like to introduce the first speaker, to Dr. Doosup Shin. So the deep dive into calcified nodule. Please.
Thank you for having me today. Good morning, everyone. I'd like to talk about calcified nodule, and I have no disclosure relevant to this talk. So calcified nodule is distinct and particularly challenging subset of calcific lesions, perhaps the most challenging lesion in PCI. And it's characterized by multiple dense fragments of calcification that protrude into the lumen. I'd like to introduce a couple key concepts. The first concept is the subtypes of calcified nodule. Eruptive calcified nodule, which traditionally was regarded as a calcified nodule from the pathologic studies, has a disruptive fibrous cap, often with overlying thrombus. If you see the OCT images, you see this irregular surface. It's considered to be biologically active and can cause acute coronary syndrome, although it's the least common cause. Whereas non-eruptive calcified nodule is a protrusion of the calcium with smooth, intact fibrous cap. So you see this smooth surface. It's biologically stable compared with the eruptive calcified nodule, and it's usually cause chronic coronary syndrome instead of acute coronary syndrome. Pathogenesis perspective, CN originates from the necrotic core calcification, which does not have collagen. It initially forms a calcium in the outer surface of the lesion, and that protrude into the inside and replacing the necrotic core into the calcification. So even if it's a calcified nodule, when you see inside it, there's a heterogeneous material. Another important thing is the necrotic core calcification, which forms calcified nodule, is flanked or sandwiched by rigid calcific sheets that has a lot of collagen inside. And that's important because we think that the mechanical force due to the hinge motion of the artery plays a critical role in the development of the calcified nodule. So if you see here, you have a collagen-rich calcified sheets, and then in the middle, there's a soft part, which is collagen-deficient necrotic core calcification with the systolic movement that accentuates the tortuosity and the torsional stress, which eventually cause the growth of the calcified nodule and perhaps eruption. A third concept, very important for interventional cardiologists, is the deformability of the calcified nodule. In this case, had a radiolucent mass in the ostial circumflex, where one of the common areas of calcified nodule. And then we did the balloon angioplasty, not the advanced lesion preparation. And if you see here in the left side, you see the very symmetric expansion, full expansion of the balloon. And so, in fact, in intravascular imaging, it can prove that this calcified nodule is, in fact, pushed away and resulting in good extent expansion. Recently, we have noticed that the subtypes of calcified nodules are related to the deformability. So, eruptive calcified nodule from Disrupt CAD studies are usually deformable, and we think that is because the broken glass, which is the calcium fragments, is on top of the soft material like fibrin, necrotic core, lipid, and intraplaque hemorrhage. So if you see the balloon angioplasty, you can technically push the calcium inside of the soft material and redistribute this nodule, and that can, in fact, we can achieve the good stent expansion with just balloon angioplasty. Non-eruptive calcified nodule can be deformable in 2/3 of cases in Disrupt CAD studies. You see still there's a soft material inside of the calcified nodule, which you cannot see from OCT due to signal attenuation. In this case, you can technically also push that nodule away and this result in good stent expansion, symmetric stents. However, 1/3 of non-eruptive calcified nodule has been shown to be non-deformable, and that's called marble and rock theory. So if you have the hard material, usually osteogenic transformation of the intraplaque hemorrhage and calcific components inside, you really don't have any space to push the nodule away. So it usually results in this kind of asymmetric stent expansion after you place a stent. Unfortunately, intravascular imaging is not helping us to differentiate these two types of deformability in terms of the deformability. We think that balloon angioplasty can tell you, in this case, you have a good stent, balloon expansion, so it's most likely deformable. Whereas if you see this kind of asymmetric expansion, not a partial expansion of the balloon, you are not ready to place a stent. Of course, balloon angioplasty has a risk and cons, because if you have eccentric calcified nodule, if you inflate the balloon, it technically pushes the soft part away, not affecting the calcified nodule, and it tends to recoil after you deflate the balloon. Another important issue with this is you have medial dissection. We've done this autopsy study with CV path recently, and then we frequently saw this kind of dissection at the interface of calcified plaque and the normal tissue. Atherectomy can theoretically debulk or reduce the size of calcified nodule, and this is what you want to achieve, really debulk the volume. However, it's very sensitive to guide wire bias, especially when it comes to the eccentric calcified nodule. So if you have favorable guide wire bias like figure A, then you perhaps can achieve some debulk of the calcified nodule. But if your guide wire or bar is away from the calcified nodule, as shown in this figure B, you will not be able to debulk the calcified nodule. Perhaps orbital atherectomy, which because of this eccentric mounted burr, you may have some benefit, have less affected by guide wire bias. And in fact, in this case, we did rotational atherectomy first, but we didn't really achieve any debulk of this calcified nodule. But after orbital atherectomy, we were able to really debulk this calcified nodule. However, orbital atherectomy is also sensitive to the speed and number of passes. And even with the optimal technique, the maximum arc diameter is about 1.8 to 2 millimeter. So we recently proved that if your lumen size is less than 2.5, you will be able to achieve some debulk of this calcified nodule, usually about 40%. But if your lumen size is greater than 2.5, then your orbit really cannot reach to the calcified nodule. You will not be able to achieve good debulk. Intravascular lithotripsy, which was recently introduced in South Korea, is not affected by guide wire bias because it's a balloon-based strategy. And the mechanism of action is the same as you achieve the fracture of the calcified nodule. And even though you don't see the fracture in the OCT, when you do the micro CT, you'll be able to see these kind of fractures. And a recent study from Disrupt CAD, we showed that the IVL is safe and effective for calcified nodule, although this is a very small study. And also we compared orbital atherectomy versus IVL in calcified nodule, and in our database we showed that the acute and long-term outcomes were comparable between the two modalities. The issue is the outcome. So even if we know that eruptive calcified nodule is a little soft, and then perhaps you can achieve better stent expansion at the site of calcified nodule. However, when you see the outcome, they are doing worse than non-eruptive calcified nodule, even though they achieve better stent expansion. One of the key mechanisms beautifully demonstrated this case where they place a stent, a great stent expansion, but at 5 weeks there's reprotrusion of this eruptive material, and then at 10 weeks you see this another calcified nodule inside of the stent. Calcified nodule is not only the issue because your final MSA frequently is outside of the calcified nodule. So about 60% of the cases were MSA was located outside of the calcified nodule. So it's not the only problem. The entire lesion needs to be prepped well. So I'd like to summarize this talk. We talk about deformability, and the stent under expansion can be due to non-deformable, especially non-eruptive calcified nodule. However, the long-term outcome is worse with eruptive calcified nodule for multiple reasons. And one of the key mechanisms of in-stent calcified nodule is reprotrusion of these calcified nodule materials. And also, it's need to keep in mind that usually the location of calcified nodule is mid-RCA where there's a lot of hinge motion. So if you place a stent, there's a risk of stent fracture. And again, MSA is outside of the calcified nodule about more than half of the cases, so always need to prep the entire lesion very well. Last but not least, these patients are sick. They're usually CKD patient, post-bypass patient, hemodialysis patients, so we really need to be aggressive with risk factor modification to treat this patient. Thank you very much for your attention.
Thank you very much. So I'd like to invite the next speaker, Dr. Carlos Collet, how to stratify calcium by CT. So please.
Thank you very much for the preparation, Doosup. I think you made my talk easier. Let's start then. And I think we have a new way of seeing calcium. I'm very excited about what this will actually generate in the field. These are my disclosures. And we all know that recognizing calcium is a challenge. This is one of the biggest clinical needs that we have in the field. And look at this case where you will say, well, not really calcified based on angiography, but if you do imaging, you will face a very severe and thick and circumferential calcification. So this is a big, big problem, especially if you're not using systematic intravascular imaging. Dr. Mintz described this a few years ago, and what we know, we can take from these pictures is that almost 30 to 50% of severe calcium is completely invisible in angiography. That basically means that almost 30 to 40 to maybe 50% of the cases that we do have a severe calcification. Now, the opportunities for CT. CT has a big penetration in Asia. In Europe, it's the first-line test for patients with chest pain. So we do have this available for the majority of patients that go to the cath lab for stable coronary artery disease. So we have defined a new way of looking at CT dedicated to interventional cardiologists. If you know nothing about CT, this is everything you need to know that is relevant to PCI. We have a 2 full-day course for you to become an expert in reading this, but today I'm going to focus on the calcium. The calcium is actually very accessible through 2 of these reconstructions. One is called 3D MIP, which are fully automated by any scanner in the market. And of course, you can understand very clearly here, looking at these 2 pictures, how this is helpful. On the left side, straightforward PCI, not calcified. On the right side, severely calcified left main bifurcation. And you understand the consequences of this in terms of access, guiding size, and of course, plaque preparation. Now, I want to focus on this, which is the richest part of any reconstruction of CT to look at calcium, which are the cross-sections. Cross-sections helps you understand the plaque composition, and when you look at calcium, it's very easy. It looks white, and if you measure the Hounsfield units, this is typically above 320. And we have a number of studies looking at the correlation between intravascular imaging and CT, and this is quite accurate, and you see the calcium mark here on CT on the top, virtual histology in the middle, and you see here how it looks in IVUS, so it's quite direct. Now, the rest of the presentation is completely new. And this is something that we have developed over the last few years, and I'm going to show you how to look at calcium. And basically everything starts with the same approach that we do with intravascular imaging, looking at the cross-sections, understanding whether that is circumferential or non-circumferential, whether it's thick or thin, and of course the length. This is the classical approach that we use for intravascular imaging. We have validated this against OCT. Here you see in the horizontal axis CT, in the vertical axis OCT, and what you can get from this is that CT is perfect to assess length, it's very good to assess arc, and has some other correlation with OCT to assess thickness. Now, when the game really changes when you look at calcium in this way. This is an AI-based, fully automatic 3D reconstruction of a calcified plaque in the LAD. You don't need to be an expert in CT to understand not only that there's a severe calcification, but for the first time, you understand that this is a calcium that is located in the lateral wall of the CT, that then goes on the top of the LAD and has a calcified ring just before the diagonal branch. And this information, again, is extremely intuitive to understand and, in my opinion, provide a lot of helpful clinical information that is, of course, actionable. We're using this in the cath lab, so basically we make the 3D reconstructions and we put that on top of the angiogram and we do this live. And this, of course, helps a lot to understand not only where the calcium is, but also where to deliver the pulses and where will be the regions that you have to concentrate on. Now, by far, the biggest advantage of CT today, this is something that we are very busy validating, is the fact that you can not only understand the arc of calcium, and I'm going to bring your attention to cross-sections F, G, H, I, M, A, V, J, and all of you will say, that's a circumferential classification. And that is true. But if you start seeing not the morphology, but the density of the calcium, then you realize, for example, that in cross-section G, this is not homogeneous calcium. This is calcium that is very dense here at 3 and at 6, and it's not dense at 12. So what I'm trying to say is that with CT, you can understand where the calcium is hard or soft. And I'll show you a few cases proving this concept. Now, we can classify the calcium then based on the density, and then we have low density calcium, which is typically below 700 Hounsfield units. We have intermediate calcium, and you have what we call very dense calcium, more than 1,000. And we have even 2K calcium, which are extremely, or in my opinion, unmodifiable. I'll show you a couple of cases, and this picture I like it a lot. It's just basically seeing here the CT, that you see the IVUS, and then you will see how complementary these two modalities are, because by CT, of course, you can see the thickness, and of course, in IVUS, you can see the superficiality and higher resolution. Now I'm going to show you what we did. This is in the cath lab. This was a case that we did with IVL. You see where we're placing the balloon, and I'm going to show you what happened after modification. Look at this. First of all, I want to highlight something that Dr. Doosup mentioned, that here you can see that this big calcium that you cannot see anything behind is basically low density calcium in cross-section D. This is what we call egg-shell calcification that Dr. Doosup explained. And when you look at the right side here, you see here where the fractures occur, basically at the level of the transition of the density in this cross-section E. Everything that you have seen in the previous slides, we are testing this in a clinical trial called the P4, a randomized clinical trial where we are testing the use of CT, both for understanding of the complexity, selection of material, understanding the necessity of advanced plaque modification, and which is the device that should be used, plus additional information concerning the mass, projections, physiology, and prediction of outcomes. This is, again, CT-guided PCI. We're randomizing the patients against IVUS. Yesterday, we have one of the final calls of the study. We have included 990 patients, so we are basically finishing the trial in a few weeks, and we will be ready to present the results by the end of next year. With that, I think it's fair to conclude that CT is not anymore a ruled-out test. This is a method that is for interventional cardiologists that provides additional information about calcium. It's extremely easy for us to look at that, and it characterizes calcium in a way that is complementary to all the modalities that we know, including intravascular imaging. I believe that when we finalize the analysis of this data, CT will certainly become a very important tool in the stratification and management of coronary calcium. Thank you very much for your attention.
Thank you very much. I'd like to invite the next speaker, Dr. Shengxian Tu. Quantification of calcified plaque from coronary imaging, comparison between CCTA or OCT. Dr. Tu, please.
Thank you, Chairman. Dear Chairman, this colleague is my privilege to present this talk. Come from Shanghai. This is my disclosure. So another CCTA enable non-invasive plaque assessment, but it has limited spatial resolution and higher inter-scan and inter-scan variability. On the other hand, OCT is a high-resolution catheter-based imaging modality, allowing comprehensive plaque calculation. So before I present the difference between these two, I would like to go a little bit more into the influence factor for the CT appearing. This is a model we built and put in the scanner using different scanning kernel. As you can see, the appearance of the calcium looks very different. Here you can see it's becoming much more blurred and become bigger airway, as you can see quantified here. But if you have a sharper kernel, then the calcium can be easily quantified from here. And we further do change the tube voltage. As you can see, when the tube voltage increase, the appearance of the blooming effect decrease as well, so the artifact decrease. And we tested in different vendors. All of the vendors have similar trend. So these two would be the most important factor affecting the calcified lesion airway. So we developed methods to adjust this calcium airway by adaptive Hahn unit-based thresholds. So the software can automatically delineate all the plaque composition, and then using the adapted Hahn unit-based plaque calculation, you can calculate the different plaque composition like lipid in yellow and green in fiber and white in calcium. So this is now becoming also available, commercially available. It can automatically analysis currently about 2 to 8 minutes, where you can see that you can have the MIP and you can have quantified, calcified lesion on top of the end lumen, and also you have the CT μFR at the same time calculate. And on the other hand, for OCT, we also have this more intelligent plaque calculation based on AI, and this has been integrated in the OCT Plus software, which you can automatically delineate all the entire cross-section and get then the plaque distribution from OCT. And at the same time, you have the OFR. And this approach was also validated in a couple of studies. This is the first study using the consensus of 3 leading international Collet reading as a reference standard. As you can see, for calcium, the concordance with this Collet reference standard is 88.5%. And we further validate in multimodality. So in this data set, we have both IVUS and OCT, and we have also histology, virtual histology from IVUS, echogenicity, and from OCT, we calculate the attenuation and the backscattering. So we want to see how this imaging modality identifies the calcium. And in order to make sure that we are comparing the same cross-section, we are using this radial or plaque marker. So using the absorbed cohort at 5 years follow-up, when the scaffolder was fully absorbed, but the radial plaque marker is still visible there. You can identify from either IVUS or OCT. You will make sure that you are comparing the same cross-section. And this is the result, as you can see. Out of 46 perfect matching cross-section, 33 of them have complete matching of all this imaging technology. There are 4 discordance. We think that's because of the IVUS, but 9 discordance because of the OCT. And if you go more in detail, as you can see here, majority are 4 out of 9 because of OCT, because the calcium is not that big, so it's just behind the guide wire. So guide wire artifact as it did not block the visualization of the calcium. And 3 out of them is because the calcium is too deep. So the deep calcified plaque cannot be imaged by OCT. So if we exclude the artifact, OCT artifact, and then you can see there's substantial agreement among different imaging modality for calcified lesion detection. So then we go to the comparison between CT and OCT. So one thing that we want to make sure is that we are exactly comparing the same cross-section, not by visual link, but more by software. So we developed 2 approaches. One is the automatic matching the CT with angiogram, and the other one is automatic matching with the OCT and the angiogram, because all the side brands are available in this modality. So using the side brands, you can matching this imaging modality. And then we can compare the slide by slide on the histology or virtual histology between these 2 modalities. So in total, we analyzed 95 patients. After excluding, we have 153 lesions from 91 patients, or pair for analysis after correlation between CCTA and OCT. And this is the characteristic. Majority are stable angina and also silent ischemia. This is the main result. As you can see, there was a good correlation between CT and also OCT in terms of quantified the calcified plaque volume. But there was a trend towards overestimate calcified volume with increasing calcium size. This does not mean that the CT will overestimate the calcified volume after the correction of the adapted threshold. Because if you look more into detail, for example, this is one of them, very extensive calcium, CT, and the OCT. So the OCT seems that the calcified area is smaller. Maybe this is the reference standard can be questioned. And also we further look into some of the study that it's ongoing. So we have some postmortem study we look in the histology and micro-CT and OCT as well. As you can see, this is the section that we, after perfect matching, from micro-CT or from histology, you see the calcium. But in OCT, you don't see the calcium here. And if you do AI, artificial intelligence, it's also missing this calcium. So maybe the reference standard of OCT need to be reconsidered, but we are going to do a larger sample for histology. After that, we can discuss the result. And ladies and gentlemen, in conclusion, the attenuation and quantification of calcified plaque were affected by CCTA scanning protocol, including tube voltage and reconstruction kernel. The AI-enhanced methods enable fully automatic and fast quantification of calcified plaque from CCTA. CCTA derived calcified plaque volume correlate well with OCT. However, with increasing calcified plaque size, there was a trend towards larger volume by CCTA than by OCT. And further future validation with histology data are warranted. And thank you for your attention.
Thank you very much.
Thank you. We will move to the next topic. Next topic is the selection of the appropriate atherectomy device for coronary calcium. This presentation will be, topic is presented Dr. Kitani. And the next topic for the rotational atherectomy tips and tricks also included in this presentation.
Thank you so much. Yeah, Dimitri regrets he has an important call with the health ministry, so he has to be on it, so he won't be there. So I'll try to cover both topics at the same time, and he'll be disappointed because he had a great case of a stuck rotaburr that I was in as well, but I don't remember it well enough to present it well, so you'll have to present it next year with him. So just keep that one in mind. So, when we talk about treatment of coronary calcium, we've talked a lot about imaging, and it's a perfect segue to this talk because there are many options out there and many algorithms and many papers talking about how do you pick all these different devices. But what's very interesting is that the only thing that has been really shown in a clinical trial to improve outcomes is not on this slide. It's actually missing from this slide, and that is imaging. And the only data that we have that when looks at imaging beyond the randomized trials, this is in specific calcified lesions from Illumian 4, is you get true reductions in hard clinical outcomes with the use of intravascular imaging or imaging in general. And I actually think that some of the data that Carlos showed and Shengxian as well about CT is really, really important because you don't necessarily have to put the imaging catheter if you have that information up front. So we actually demonstrated this too within the ECLIPSE trial, and this was a trial looking at atherectomy, and that's what I'm supposed to speak about, versus NC balloons for severely calcified lesions. And what we basically showed is that when we used imaging in over 60% of the cases, we showed similar imaging outcomes with an NC balloon compared to an atherectomy device. And so why am I presenting this data when I'm supposed to talk about atherectomy? And the reason I'm showing it is because it's really important to mention, and this was actually changed in the Lancet title of the manuscript, that the patients in the ECLIPSE trial had to be eligible for both treatment strategies. In other words, there were not patients that had balloon uncrossable lesions in that trial. And similarly, undilatable lesions that really needed to use atherectomy or something else were not in this trial as well. So despite the fact that there's no true clinical outcomes data, it's very important to mention that atherectomy still has a role. So what is the data in imaging, where does it stand right now? Because the CT data that you showed in the prior two talks is interesting, but it's not in prime time use yet, but intravascular imaging is. And this is a paper that Akiko led with one of the IVUS fellows at CRF, showing us that if you have angiographic calcium, that's not good enough to detect whether you need to use an atherectomy device or not. And that's what we clearly showed in the ECLIPSE trial. But if you have 270-degree calcium that is 3 millimeters or more in length, or a 360 arc, or calcium thickness greater than 0.3, if you have all three of those things together, then you really need to think about using an atherectomy device or IVL. Importantly, though, if you don't have all three of those, and it's actually really nicely written, Akiko had written this at the bottom of the figure, it actually shows that you can usually try with an NC balloon because it's going to work in a significant proportion of the time. 40% of the time or more. And so this is an important score, and there's a lot of confusion about the score because the inflection point is really when you have all three criteria, not just 2 out of the 3. Now, in terms of how do you pick a device, so I'm going to talk a little bit about both orbital atherectomy and rotational atherectomy. And the reality is that you can use either for most cases of severe calcification. If you only had to pick one, The answer is we're going to be rotational atherectomy for the reasons I'll mention. So orbital atherectomy, you have multiple choices of wires. In general, you use a floppier wire. It's a single device. You can do everything through 6 French. It tends to have a better hemodynamic stability as a whole, and you can use this feature called glide assist to get through specific areas that you don't want to ablate. The setup is perhaps a little bit easier. With RotaPro, the setup is actually well done as well, and one of the nice things about having multiple devices is that each one competes to get better. And so for Rota, you can do front cutting. It's really important because it doesn't orbit, it doesn't circle, it just is more precise in a sense. And so if you're in the subintimal space or in a more angulated or tortuous lesion, it's going to be more precise. You can go up to 2 millimeters. We heard in a prior talk that you can't quite go that far with orbital. And then for specific indications, it's probably going to be safer, like rotablation of a stent or otherwise, and it's a lower cost of a single device. But I do want to emphasize that either could be used in most cases of severe calcification. Now, I'll show you some cases. And so this is the case, an LED diagonal. You can see by the angiogram there's calcium. I guarantee you if you assessed it by CT, you'd see there's calcium. And personally, I think that volumetric assessment is going to be really important because that's harder to appreciate oftentimes when you look at intravascular imaging. So what's going to be your strategy? And so what I thought I would do is I would do imaging to see what the LED looks like first and then go from there. And so actually the imaging of the LED showed the LED wasn't severely calcified, so I dilated both the LED and the diagonal, but the IVUS would not cross into the diagonal, and part of the reason is it goes up, and down again. And so this is after a lot of predilatation, the stent doesn't go. You don't want to force this, you're going to strip the stent into the left main, and so you can try more balloons, but at this point, it's safe to do rotational atherectomy even if you have an undilatable lesion. So because Dimitri was going to talk about Rota, I didn't talk about the scenarios of uncrossable lesions. Rotational atherectomy, very safe to do in those purposes. In fact, it's probably the only thing you can effectively do in many of those cases. But for even lesions that have been dilated, you can very safely use rotational atherectomy around a bend in a smaller vessel. And after rotational atherectomy, basically everything was much better, and we were able to do bifurcation PCI with a mini crush stent, and this is the final angiogram. I did have to go extend it further down, but that's okay. So you can get a good result in a relatively small size vessel with angulation. Now this is just an example of orbital atherectomy. There's disease in both the OM as well as in the left main. If you were going to do this case with rotational atherectomy, you would probably use 2 different devices, one bigger size for the left main, smaller size more distally. In this particular case, microcatheter wouldn't cross that distal lesion, so we basically wedged a microcatheter here, exchanged it, and the Viper wire is a nitinol wire. It's actually very nicely manipulable. That's why the Rota wire now has the Rota drive, which is actually a very nice wire as well. These cases used to be very difficult to do where you free wire it, but in this case it was fine. And then the strategy for orbital atherectomy, which was 6 French from the distal radial on the left, was to basically do low and high speed here and only do low speed there with very, very careful movement to stop here so it doesn't jump around the bend. And the same thing is true with Rota, tips and tricks. When you go, you can't go so fast that you're flying around the bend because in a small vessel, that's how you get perforations. And so basically the intervening segment, we weren't going to ablate. We use this 5,000 RPM glide assist feature and just go from there to there. And that's basically what happened. This is what it looks like after orbital atherectomy. And then basically it's just simple stenting and optimization. And we did high speed at the left main. Final IVUS, I'm not going to show you, but basically everything looked good. And this is what the final angiogram looks like. So you can do these cases with a single device safely. Now, another case that I thought I'd show, just because I know orbital is not so available, but it's a nice thing to have, is this is a case, I'm a radialist, this is a horrible guide support, there's a tortuous calcified area of the LAD, and there's 2 segments of LAD with heavy, heavy calcium here and then down here as well. The guide is terrible and nothing's going to deliver. I put a wire in the circumflex, it's horrible. Even with a guide extension, it's terrible. And even with a balloon, there's a waste on the balloon. So I need to do atherectomy, but what am I going to do because I have a guide extension down? Well, with a 6 French guide extension, you can do orbital atherectomy. You can try to do a 125 burr as well, but in this case, it was perfect for this setup with orbital atherectomy, and I only did orbital atherectomy of this lesion, and I did not want to go down more distally in this other lesion. And so when you do rotational atherectomy, you need to think about the case and know where the danger points are so you can do it safely. And so basically, this is what it looked like afterwards, and then this was going to be dilated with a balloon. That's basically what I ended up doing, deploying the stent. You can actually do an OCT through the guide extension, and this was the final result of the LAD. Now, the reason I stress safety with atherectomy is because you have to often do atherectomy, but you have to do it safely. And there are many people that are worried about doing atherectomy because they're scared about it because they've heard of complications or they've had them themselves. One of the nice things about the ECLIPSE trials is a randomized trial of over 2,000 patients showing that a balloon-based approach versus an atherectomy-based approach for lesions you could do both actually had similar rates of procedural complications. But that doesn't mean that the devices were identically the same in terms of safety. And so when we look at our 30-day outcomes, and this is also in the Lancet, what you see is the rate of cardiac death at 30 days was 8 versus 0. Orbital atherectomy, 8, 0 with balloon angioplasty. So we went over these cases one by one, and I can tell you there are a few lessons that are learned from them. One of them, with any atherectomy device, is if you have severe angulation and you put a wire down the vessel and there's no flow in the vessel after the wire, you don't want to do atherectomy in that case. Another case, occluded LAD, severe calcium, EF of 20%. Atherectomy was done of multiple circ branches, and then atherectomy was done of the right coronary artery after that, and sure enough, the patient had hemodynamic compromise about 6 hours later, because we know that atherectomy causes embolization. So all these cases you need to do very carefully and be selective about it. So this is just an example of a case that as a patient I follow, I didn't do the case, I can say that with assurance. This is a very, very angulated circumflex. This is a wire that's down, and I think you can see that the wire is going kind of almost looks like outside the vessel here. Would you ever atherectomize this lesion? I can show the panel, ask the panel, would they ever take an atherectomy device around the bend of the circ? Everybody's shaking their head no, but in fact, it was done. Somebody did atherectomy in this case, and sure enough, what you see is a nice big perforation that happens as a result. Very predictable, but the point is if you don't have the experience, you may make this mistake, which is why I'm showing the case. Thankfully, this was actually solved by covered stent, which somehow at that time with the Joe-Med delivered, and the patient's doing very well. He's 90 plus years old and is my clinic patient. So final case I'll show you is how do you avoid these risks? Well, there are maybe other devices too. So this is an example of a left main. You can see there's a nice big nodule right here at the distal left main. You can't see here, but it does involve the ostia of the circumflex. What was the strategy? So I thought I was going to do atherectomy, but I might have to do multiple branches. But one of the problems is even a microcatheter has difficulty getting into the circumflex. You can see the guide kicking out. Even with spinning of the microcatheter, you're going to have problems. So it's very tight. You're going to have to probably do atherectomy or maybe not. And so what actually I did in this case is I did imaging. And when you do imaging of the left main coming back, what you'll actually see is the nodules in the left main, and you'll see the wire of the circumflex is right next to where the nodule is. So the nodule's here and the wire of the circumflex is here. I'm going to let this play again from here. Here it comes back. So the circumflex wire will come here, and the nodule's right here. There's a circumflex wire, and there's a nodule right there. So actually, I said, well, maybe instead of having to then atherectomize into the circumflex, what if I just modify this plaque in the LAD? And so basically, in this case, I did lithotripsy. So I took an IVL balloon from the left main into the LAD. I used the fact that that wire was next to the nodule. And after doing that, this is what the picture looks like. And you can appreciate all that haziness that was there at the ostia and the circ is better. So I then IVUS again, and you can see in this imaging run that proximity of the wire to the nodule is a little bit different now. So see now where this wire is coming? That area is cleared away because the nodule sort of fractured and got pushed aside. And so if you don't believe it that way, the other way to do it is just to put a balloon in there, and balloons now cross much easier, dilated, and then re-IVUSed from the circumflex distance. And if you look at this as it comes back, what you'll basically see is the circumflex ostium now looks much better and is not obstructed by the nodule that's in the left main. It's coming right there. And so what stent strategy? At this point, I just did crossover of the circ with pot. And after doing that, this is what the final angiogram looked like. Circ was open, everything was fine, and was able to do this without using atherectomy. And so this was a case where I think that risk benefit of going around the bend was mitigated by the use of another technology such as lithotripsy. So what's our image-guided approach to calcium? We use the device that works in calcium, and that's imaging. What we do is if there's a long, severe stenosis or uncrossable, just upfront atherectomy, pick your device based on the scenario, what you're comfortable with. You can typically do a quick try with a microcatheter and a super low profile balloon, but you might be in for a long case. You then do NC balloons with mandatory imaging to confirm that you have fracture in preparation, IVL if needed. If the lesions are less severe or balloons cross, what we do is we do image first, and then if it crosses, we're just pre-dilate first, and then based upon the scoring algorithm that Akiko is so nice to publish, we then choose our device. And if the device has all three criteria, you're going to go up front with IVL or atherectomy. If it doesn't have those, I'll start with an NC balloon on the basis of the ECLIPSE results. And then after we prep, we go back and image to be sure that everything is cracked and fractured accordingly. We always want to do that before we put the stent in, because if you put the stent in and it's not going to expand, that's the worst problem ever. And if those things don't work, we can use atherectomy or otherwise bailout. So thanks so much for listening. Sorry to take both time, but thanks again.
Okay. Next topic is the calcific nodule or nasty beast, how to tackle. This topic will be presented by Dr. Basabara Zia.
Good morning, everyone. Thank you so much for the kind invitation. So, as the last speaker, I think most of it has been covered, so I will go through this again. So, I have no conflicts of interest to declare. So, as mentioned earlier, calcified nodules are masses protruding to the coronal lumen, and they're eccentric with generally not much disease on the other side, and it's encountered in approximately 22% of the calcified lesions we see. Again, described before, eruptive nodule which have irregular surface with thrombus and fractured plaque, and overlying thrombus. It's probably more easy to expand because of the softness of it, but it's almost like a local cancer because it can protrude through your stent and have a recurrence in the future. Non-eruptive nodule is much more hard, like fibrous cap, with no thrombus, more resistant to expansion. So, treatment challenges. So, all these cases are high-risk intervention. You can acute vessel problem like perforation, you can have suboptimal result like stent fracture, stent thrombosis, and of course, long-term risk of stent failure, especially in eruptive nodules. So for me, when I encounter these patients, they're generally elderly with renal failure. For me, medical management is okay, especially if they've got stable angina. So I've got a decent number of patients being managed medically on ranolazine and nitrates with no need for intervention. But if that fails, then you have no choice to intervene on these lesions. So let's look at the balloon-based treatment, which mainly works on barotrauma, like non-compliant balloon, cutting balloon, or OPN. The risk, obviously, is in a concentric calcium, as you could see in this beautiful slide by Optima Group, that when you expand the concentric calcium, it kind of uniformly breaks the calcium. Whereas if you do in an eccentric lesion like calcified nodule, it goes more to the non-resistant area. And you can see in this picture here, there is a wire bias significant, and you could see the balloon is expanding more to the non-calcified area, and you can see in the schematic. And what happens when you go high pressure? You can have a perforation. So for me, IVL is one of the safest technologies because it does not purely rely on the barotrauma, because you're inflating the balloon for just 4 atmosphere, unlike the other balloons which sometimes go up to 20 or even beyond 20 atmosphere. And because it also relies on the shear stress and tensile stress, you get multiple fractures, not only in the superficial, but also in the deep calcium. And you can see in this slide where you can see deep calcium within the vessel. And this is one of our cases. I've shown you both the IVUS and the OCT. So this is pre-IVL, and this is post-IVL. Not only you see the fracture, but you get a better lumen gain. So when do you need atherectomy in calcified nodule? Obviously, the commonest reason is that if you can't pass any IVUS or OCT probe or even a small balloon, you have no choice. You have to rotablate. But for me, if the lumen is less than 2 millimeter and if I have a favorable bias, I use rotational atherectomy because I feel it complements your IVL technology, because atherectomy is a debulking tool, whereas IVL is more like a cracking tool, so they can be complementary to each other. However, there are some tips and tricks I would say for atherectomy when using for calcified nodule. You have to take at least 1.75, maybe even 2 millimeter burr. And of course, when you take such a big burr, there's a risk of slow flow, so be prepared. I use only verapamil and heparin. I don't use nitrates in my rotor drip. But I also have this more than 5 drips per second, so I want the solution to be flowing with high speed so it can diffuse all these particles we create. And of course, I start with the high speed, and then I drop it to 140, and you need to spend a lot of time in these nodules, maybe short runs, but you need to do more runs here. I have limited experience with orbital atherectomy. As alluded by Ajay, there are, of course, risk of slow flow, and also it cuts the non-calcified areas as well, so there's a risk of perforation. And laser, again, it's not universally available in all centers. So with this, I would like to show a couple of cases. So this is a case of a calcified nodule in the proximal LAD. And obviously, we did the upfront imaging here, and you saw the calcified nodule. The lumen was more than 2 millimeters, so we went straight with IVL balloon, 3.5, and we did all the 120 pulse in that area. And this is important. After the IVL, you have to take a balloon to expand it. So we took an NC balloon at high pressures, and we did the OCT, and you could see this fracture, but also this lumen gain. And when you compare it before IVL and after IVL, you can see the fracture and the lumen gain. And then we used a drug-eluting stent, and we had a good result on the OCT. One other thing I would say is that don't expect a round final result in these eccentric calcium, even nodule, because if you have an MSA of more than 6, that's more than enough, because trying to achieve perfection, you'll end up having complications. The second case is more complex, 75 already with ACS, hypertension, diabetes, and renal failure on hemodialysis. And this is the angiogram. You could see the LAD is diffusely diseased like a classic diabetic and a renal failure patient with a calcified nodule in the ostium of the LAD. So we tried to do upfront imaging, but unable to pass the IVS probe. So we have to perform a rotational atherectomy with both 1.5 and 1.7 millimeter burr. After that, we did the imaging, and we saw so much fractures. This is amazing because a lot of the time we jump straight into IVL, but when we did the imaging after a rotational atherectomy, we had a lot of fractures. We did more aggressive ballooning. Balloons expanded nicely, and we did the repeat imaging, more fractures, more lumen gain. So we decided to treat this without any further balloon dilatation. So treatment strategy, where would you start and where do you stop here? Because it's a diffuse disease, and she's got renal failure and diabetes, so full metal jacket will result in stent failure over time. So we went for a hybrid strategy, so we used DCB in the mid and distal LAD, and we placed a stent in the left main to LAD with a good MSA. And this was the final result. Again, it doesn't look great, especially in mid to distal LAD, but for me, there is flow ischemia 3, and there is no significant recall, so I'm happy to accept this. I didn't want to place any stent. And we wanted to bring this lady back for an angiogram sort of 6 months later, but because of the COVID, we could not bring her in. So finally, she came for an angiogram 18 months later. It's not bad. I mean, there is still some recall, but on the whole, the lesion looks great, and she was completely asymptomatic. So thoughts for the future. The next 2 slides I will show. Maybe we should probably consider DCB over DS, especially some of these eruptive nodules, because it's like the way saying DCB failure is maybe forgiving than stent failure. The next thought is this is more controversial. So we have had cases where sometimes we rotablate with ping pong guide with the fine cross or a caravel protecting the other branch. And we have seen that there's absolutely no damage to the rotational atherectomy because it only cuts the calcium, differential calcium. So we did this, like for example here, we did the ping pong guide, we rotablated the LAD, and then we rotablated the circumflex to ensure that we didn't lose the branches. I don't know, this is purely hypothetical, and we've been discussing with Colombo about this. We should probably do some bench testing and maybe do a ping pong, take a balloon, improve the wire bias more towards the calcified nodule, maybe we'll get more debulking. Certainly, I've not tried this in any patient, so don't worry for the future. So finally, calcified nodule is a treatment challenge with high risks. IVL is effective and low risk tool. Atherectomy can be complementary, especially if there's a favorable wire bias. And so don't aim for perfection. MSF more than 6 usually sufficient. Thank you so much.
Thank you. Nice presentation. Actually, we have 5 presentations. Now it's time for the discussion and comment about the 5 topics. We have a lot of the discussion time. Any comment? Very interesting.
Yeah, I have a question to Akiko. Those calcified nodules, I mean, in general, especially when you see it on the left main arm, pathologically wise, can they also shift? I mean, make a plaque shift as a nodule, or if there is a nodule, there is no plaque shift. Because sometimes we observe that, right? We have an, let's say, calcified or a kind of nodule which is on the LAD left main, but not at the circ. But then we do a great plaque preparation, put the stent, everything, and then we see a shift. So when do we have a shift? And can a nodule shift?
I think we had the data. We analyzed that question, meaning like when we do the left main, distal left main stenting, and then say we try to provisional. When we fail, meaning when we need a second stent because of the failure. And one of the very important predictor is the presence of the calcified nodule in the distal left main. But I don't think that's a calcified nodule shift or a plaque shift because of the calcified nodule is really big and then making more, I don't know how to call the plaque shift or a carina shift, but just making the enough space, they cannot change the other side. So the most of the time, if you have the calcified nodule at the left main, that's the most important predictor of the failure of the provisional.
Any comment? Any comment?
I think I want to mention a little bit in terms of the calcified nodule. We have the very nice talk today, but there is, I think, two important aspects which not mentioned today yet. Number one, whenever we see the calcified nodule, we are overestimating the diameter stenosis most of the time because calcified nodule is protruding and then behind there is a space. And most of the time we have much larger lumen when we do the imaging. So because this is a very difficult animal, so before start treating, we really have to ask ourselves, this is really physiologically significant. That's very important, I think. And secondly, we should not forget the medical treatment because those are the so-called active calcified nodule, calcium. And then when we look into the what type of the calcium is causing the new calcium development, and we see the calcium with lipidic plaque, it's consistent with the pathological finding. So even though we think the calcium is stable plaque, there is a lot of lipidic plaque behind, and they stabilize, and then try to reduce the progression of the calcified nodule or stabilize the calcified nodule. That's, I think, even the calcified plaque, that's very important.
Maybe we had a very nice lecture from Dr. Shin on calcified nodules, and he explained that even with the non-eruptive calcified nodule, about 2/3 of them were deformable and maybe 1/3 weren't, and was saying that it was very difficult to distinguish between the two, and maybe only with a balloon we could distinguish. But obviously there's been some publications on dark nodules or light attenuation. Do you think we can use light attenuation or the so-called dark nodule to predict expansion?
I'm sorry, are you asking me?
Or Dr. Shin?
I think actually I would ask the Carlos. OCT is no help at all. IVUS no help at all because everything is attenuation. Even the non-eruptive OCT, everything behind is attenuation, no help. So I think the CT probably the best modality because CT can see the thickness, and then when we see the heterogeneity of the CT Hans field unit, and probably so-called based on his definition is immature calcium behind, that's probably we can predict better than OCT. I would hear the opinion by Carlos or Dr. Shin.
I think that I agree with that. We've been looking at the CT Hounsfield unit and the correlation with the deformability. Another thing that's hypothesized is that if you have a NIRS on top of OCT or IVUS, sometimes if you see the NIRS, there's a high lipid rich plaque behind the calcium that you cannot see, and we have actually a case that we were able to push that out to the lipidic plaque. That's one thing that you can try. But obviously, I think the CT will be the future because now with the photon counting in our institution, we're able to really identify the calcium, and not all the calcified nodules are the same. You know, they're very different, even though you see the same in the angiogram. So I think that's one thing that will be the future for predicting, you know, which calcified nodule can be deformable with just balloon angioplasty.
But in general, the question is, I mean, when we have CT for the pre-planning, like in the P4 study, what's the value of post imaging after stenting now? Because in the P4 study, there is no image control, right, in the CT arm. So do we need, I mean, if we do proper plaque preparation, do we need a post-evaluation after stenting anymore? So that's a good question, right? Because that's basically what the study is going in the direction. So if you have a good CT and you know how to prepare your plaque, and maybe it's non-inferior. So the question is then, do we even need a post-evaluation after stenting?
Yeah, so I think the P4 trial, we used the device detection or any kind of advanced angiographic tool. In our institution, it's the device detection, clear stent, stent Vs, whatever you have available in your lab. We really want to see the full expansion of the balloon to be able to really ensure the good stent expansion at the end. We enrolled a couple patients, and in my personal experience, I'm very heavy intravascular imaging user. And then still, because I was trained to use intravascular imaging in my practice, so even if I see the good result, I still want to see the etch. I still want to see, other lesions that I miss. Or nowadays with the high-risk plaque, if I'm landing my stent in the high-risk plaque, although that information you can have from the CT scan. So I do think that we can replace the MLD part, which actually really is very helpful. And we actually demonstrate in a couple live cases that you actually bring all the equipment to your lab even before you actually do the diagnostic angiogram, and then you actually know where is the high-risk plaque. So we may need to place 48 millimeter instead of 30 millimeter stent to cover the high-risk plaque from the CT scan. Although we don't have the evidence to prove that's beneficial, but I think we can pretty much replace the MLD part. But still, to me, I think the max part, which is maloposition, edge dissection, and then stent expansion. I think in that perspective, there's still a role for intravascular imaging. It's not always feasible to detect those things. Although again, in Lumion 4, any studies, if you see, there's always some heterogeneous result. Like not one, unless there's stent expansion or MSA, some studies shows a benefit. A worse outcome with the edge dissection. The other studies show no. So I think to be able to show the clinical benefit may be very difficult because you need a lot of patients to prove that that's beneficial.
Is there Dr. Collet? Is there Dr. Collet? Any comment? Okay, he's not here.
So you show the elliptic calcium nodule is the worst outcome. So usually the elliptic calcium nodule exists at the hinge point. So do you think the stent itself is the cause of the...
I think so. Yeah, because when we see the calcified nodule inside of the stent, it's very hard to diagnose the stent fracture. So even though we are saying protruding, some of them, I don't think that's a lot, could be due to the stent fracture.
The speakers said that maybe TCB is more favorable for the DS in the calcific nodule. Is there any discussion about why TCB is more favorable?
No, I mean, I think I just mentioned it because we have used quite a lot of DCBs in calcified lesions, not necessarily for a calcified nodule. And
yes, had specifically in the calcific nodule.
Yeah, I mean, again, there is hardly any data in the literature on this. So which is what I'm thinking maybe in the future we should start looking at the DCB in those, especially eruptive nodules, because it's much more expandable. You're making more fractures. Maybe the drug goes in better than non-eruptive nodules. Because, as you said, once you put a stent in, and if it failed, it's very difficult to treat that. So, yeah, but calcified lesion is not a contraindication for DCB.
I'd like the other panelist opinion about your...
Yes, so Dr. Sandeep mentioned, so of course, DCB is sometimes effective, but sometimes not effective. But as you said, so the stent in the not expanded calcified nodule or calcified region is more harmful. So for us, for expert, we can do the aggressive low tabulator like you, and so we can get enough preparation or lesion modification. But in some situations, not so expert doctor, so they cannot judge. We can put the center. We should not put the center. It's a very difficult point. So we should make clear more at the point.
Okay, excuse me, Dr. Santos, please.
Yes, I have a question to either Akiko or Ajay regarding the new OCT calcium scoring. system, which has, as you said in your publication, better area under the curve or sensitivity or specificity in predicting stent expansion. But the prerequisite for this scoring system is that before you calculate the score, you need to have at least 270-degree calcium arc. But I'm afraid if we use this scoring system, then we may miss patients with lesions with significant calcium nodule.
Yeah.
What do you think?
I agree. I think, okay, so we have 2 score or 3 score. 1 score is before. That's actually, at the time that we published a long time ago, we including any calcium, even 30 degree of the calcium, 60 degree of the calcium. Some of them was not important calcium at all, but we included everything because we didn't know. And then retrospectively, we went back. If the calcium is less than 180 degree, what is the prevalence of the stent and expansion? It's like only 4%. It's very rare. So we thought we should focus more important calcium. That's all the idea. And then we start 270. That's the right kind of consensus which we consider enough calcium. And then that idea is more than 270, longer than 3 millimeter. And what is most important compared to the first one is the thinnest calcium thickness, because that's the most important predictor of the calcium fracture. And then that's 1 score. And then last one is circumferential. And why we didn't include in the calcified nodule is because simply that's cohort. We don't have a lot of calcified nodule because we already intentionally treating the calcified nodule using the low tabulator obituary already. So I think we put that comment onto the paper. Please be careful of the calcified nodule. That's a different animal. And the reason why we didn't put is because of the bias cohort. So we don't ignore the calcified nodule. That's completely different animal and important. That's a message.
As the evidence base of the medicine, actually, we does not have much data in the randomized trial in the calcific region. Recently published the Eclipse trial, Dr. Kijani, what is the clinical application of the Eclipse trial in the calcific region? How we do that, treat the calcific region?
Thanks for the question. I think the key is that you basically need to, well, however you create a fracture, however you get the result you're going to get a good outcome. And so the key in the trial is that the balloon arm did so well because people were really meticulous in how they applied NC balloons. I also think from a cost containment standpoint, it's great to use IVL in every case. One of the things that will come out of P4, I'm sure, is that there's probably a lot more use of IVL in the P4 patients that have severe calcification. But you don't know if you need that or not, and there's no harm in trying an NC balloon first, looking with imaging then, and if it worked, then you don't have to spend another X thousands of dollars to then use an IVL device. So from my standpoint, I think the main implication is that we need to do trials. The imaging endpoints are going to be good to be able to assess what happens, and we always have to think separately. So the question about the nodule is important. It's a separate beast, totally different. But for everything else, you can use scores, you can use your eyes, and you can use the imaging to be able to figure out how to treat patients.
Dr. Kotani, you showed a very angulated circumflex artery case with calcification, and finally after the rotabulation, it was ruptured. So I saw some straightening or accordion effect by wire, so it may increase the risk of rupture. So going back to the case, how would you manage the patient? Can we just do the IVL in very angulated circumflex artery case?
Yeah, so great question. I think regular balloon or IVL would be fine. The IVL might not cross because the IVL is also a little bit more bulky. But the key teaching that I would say is that if you're ever going to do atherectomy, you put the wire down and you look at the initial angiogram. And if the course of the wire is different than the way the initial angiogram looked like, or if you inject dye and you see everything is straightening out, that is a higher risk of perforation type of case. And you have to be really careful, or you abandon that approach and don't do it that way. The mistake I see people make is they think the artery is the same with the wire down as before the wire was in, and that's a big mistake and can lead to perforations, which is the most devastating complication of atherectomy.
Okay, thank you. Dr. Tu, I have a question. Quantification of calcium is very important in the treatment of calcified lesions. So my question is, what do you expect the what do you expect that AI-based quantification of calcium amount can affect the clinical practice?
Thank you for the question. I think the AI is more like making the CT reconstruction much easier, because in the past, if the interventional cardiologist only look at the report, it's not good enough. So if you can get access to the diagram and you have AI, you can really appreciate all the information from CT. And that would be not only the quantification will be more accurate, but also how to use the CT information, like Carlos Collet shows that using the on-site, but also you can use get the optimal viewing and then see the distribution of the plaque composition before you really making your treatment strategy. I think that part would be very helpful. And the quantification of the heterogeneity of the CT indeed is possible, because you can see the Hahn unit is going to be different among CT, in the calcified region. However, you need to be careful, because different CT scan, the CT Hahn unit can be influenced as well, different. So to have absolute value, we need more validation, and vice versa. OCT, I think you can also have some attenuation analysis from different calcium that could provide some information for the heterogeneity. So this information can be integrated maybe with AI.
Thank you.
So I have one question. Dr. Kitani, you show the great cases circumflex guide wire deviation, but I have bad cases. In the IVL of the diagonal branch, the guide wire moved to the behind the calcium. So it's very hard to
predict.
Get a true lumen. So we have finally stand to the subintima. So don't you have this kind of case?
We do. I mean, actually, Akiko and I were talking we have a series of cases where with the IVL, you get opening of the ostium and it looks better. But we don't know if that's going to happen or not. And sometimes, I mean, rarely, I guess it could get worse, especially if there's a flap or something like that. But we need to study more what the orientation was. I think in this particular case, it was a risk-benefit calculation. I could take the atherectomy around the curve, but I would have been more uncomfortable doing that. So that's why I picked it this way. But I think that in general, if it's alongside, it doesn't usually slide behind. I don't know. Anyone else?
Is it possibility is the bifurcation angle?
Yeah.
Because of the left main and the circum, the angle is very wide, but the diagonal or the OM very narrow. So
possible.
I think this type of scenario, I see some number of the cases. When you have the big calcium and the wire is behind the calcium, and then you end it up the subintimal stenting, I see at least 5 to 10% of the calcified region. I see this. I don't think that's specific for the bifurcation. And he has a question.
I have a comment. So regarding the Eclipse trial, there is a great trial, but considering that the MLA was 7 something in the balloon angioplasty group, some patients might not have severe calcification. So if we exclusively enroll patients with severe, heavy calcified lesions, I do believe atherectomy or IVL can improve outcomes. So, and a difference in MLA smaller than 5.5 might affect the clinical outcomes, but difference in MLA greater than 6 or 7 might not translate into the clinical outcomes as in the Eclipse trial.
Yeah, it's a great comment. I think some of it has to do with the fact that the way the vessels were qualified was based on angiography for the most part. But angiographically, it was severe, 97% severe by angiogram. But by OCT, it's not as severe. And so the lesson is that the imaging tells a different story. And CT may be helpful in that regard too. But basically what we've used in clinical practice for 30 years, I mean, it's the 30th anniversary of this summit. Everybody looks at the angiogram and they say, wow, that's severe calcium. I need to decide how to treat based upon what I see. That's not correct. You need to do something different.
In your trial, is a subgroup analysis, is OCT guided group, that the orbital atherectomy is significantly the reduction of the MACE compared to the conventional group. No?
So no difference in MACE, but Akiko can comment a little bit because she actually just submitted that manuscript looking at the OCT analysis of what exactly was found.
Yeah, event rate is actually even the OCT cohort, knowing what amount of the calcium is
In the subgroup of the OCT,
Huh?
OCT guided group.
Yeah, so that's I'm talking. Yeah, it's same. But I think compared to the non-OCT cohort, the event rate is almost half.
I have a very practical question to Dr. Basavarajaha. So you show the ping pong technique is very fancy because I've never thought about that. But if we use a bigger size of the guiding caster, like a 8-French guiding caster, then still can we place the wire to side branch and then perform the rotation with a single guiding caster, or still do we need to use ping pong technique to avoid any damage to the wire?
That's a good question, actually, because if you take an 8-French guide, you can do it, but if you're going up with a Dynaglide, you'll be kind of risking the damage all the way through the guiding system. Whereas if you take a ping pong guide, the contact for the burr into the fine cross or a caravel is very little, so which is why we did in that case. But you're right, you could use 8-French, but you may not have to go with the Dynaglide. You can probably go without the Dynaglide into the lesion. So I prefer Dynaglide, so which is why I took 2 guiding catheters, and it worked.
And for the technique, we should protect the wire using microcaster?
No, I just leave the microcatheter and take the wire out. So when I'm drilling the left main to LAD, I put the fine cross or a caravel, and I take the wire out. So I don't want any wire there. And then, of course, after that, you exchange to the rotor the other side, and then do the same, and then you protect the other branch.
I think we just have to have a bit of caution about this, right? You showed nicely on the outside the body, right, that you can put the burr right next to the microcath, they have no damage. But this all depends on the amount of force that you're applying with the burr to the microcatheter, right? Because we've all seen guide extension catheters where we've done atherectomy through where the guide extension has been damaged by the atherectomy. And again, if the burr comes in contact and it's not sliding along, but is actually, the sort of pressure on it is higher, you will cut that microcatheter. So I understand the concept, but the concept depends on exactly like when you come in contact with the normal vessel, right? If you're not got a lot of pressure on that, you don't cut the normal vessel. But if you have extreme bias towards the normal vessel, you cut the normal vessel. The same thing will happen with the microcatheter. So I just...
No, sure, I agree.
A word of caution.
Exactly. I mean, this is an extremely... I've done maybe 2 cases in the entire 9 or 10 years. So it's not like routinely do it. It's extremely distal calcification, distal left vein, severe bifurcation lesions. I was worried that I'll lose the circumflex, which is why I did it. But I wouldn't recommend doing it routinely just because you have a bifurcation. So yes, I agree totally with Scott.
Sorry to interrupt. It's time to close. I'd like to appreciate the 5 presenters and all panelists. Actually, I really enjoyed the hot discussion on this session. Thank you.